Hi, my name is Leda McDaniel. I am a doctor of physical therapy and currently practicing as a physical therapist in an outpatient orthopedic setting. Today, I want to talk to you about rheumatic disease, physical therapy, screening, and management. So, what are rheumatic diseases? What characteristics can you think of that might be unique to these diseases in general? And can you think of any in specific categories or specific names of rheumatic diseases that you might be familiar with or come across in a physical therapy setting or in the general population? Can you think of any? So I want to start general, and then we'll get to some of those specific diagnoses. Rheumatism, by definition, is any of our various conditions characterized by inflammation or pain in muscles, joints, or fibrous tissue. So a lot of what we see in the musculoskeletal system. As you can see, this might have a lot of overlap with some of our musculoskeletal conditions that we are primed to evaluate in a physical therapy setting. Rheumatism, just a little bit more about the word itself. I'm kind of a word nerd, so the etymology of that, and this will give us a clue into what are some unique characteristics of these diseases, is this word comes from the Greek rheuma, which means a discharge from the body. So you can think of a discharge. What comes to mind is that this is indicating component of these diseases that produce an immune response. So discharge, like a mucus discharge, in somebody who has a cold or systemic effect on their system. So rheumatic diseases versus musculoskeletal injury, we can think of if somebody has an immune disease or an immune component to the signs and symptoms that they're presenting with, they likely have an inflammatory component, because we know that the immune system, via innate immunity and its first response to some sort of illness or injury, is going to react with this inflammatory response. And the four cardinal signs of inflammation are going to be redness, pain, swelling, heat, which we commonly see within musculoskeletal injury. So these are pretty familiar to us. How are we going to differentiate if these are present in our musculoskeletal cases and also in rheumatic disease? Like I said before, there's a good amount of overlap. How are we going to distinguish and come up with key identifiers to these rheumatic diseases versus what we're commonly seeing? So with rheumatic diseases, the components that start to differentiate these disorders from a musculoskeletal origin is that they're autoimmune diseases. So they are conditions where our own immune system is somehow attacking itself. They are chronic and progressive in nature, so they're characterized by periods of flare-up and remission, usually, and as the disease progresses, usually increases in severity, or there's sequelae that become more and more debilitating or troublesome for the individual affected. Signs and symptoms, like we said before, often affects joints, muscles, bones. There can be swelling, stiffness, pain. But really, we're going to key in on these systemic signs and symptoms where there's this immune response because the immune system is maladaptive. So you can see things such as malaise, fatigue, chills, and fever, which are more systemic. There is testing that can be done for these specific diseases, and we'll talk a little bit about these as they're relevant to the different diagnoses or different disorders. So general inflammatory markers can be heightened, indicating the presence of inflammation. So C-reactive protein or a high erythrocyte sedimentation rate could be present. There's specific antibody testing that we can do to identify the presence of certain autoimmune antibodies. So rheumatoid factor, Rh factor, and rheumatoid arthritis is a common one. We'll discuss these others when we get a little bit further into the presentation. Imaging can be done to detect certain joint changes, and that can help with diagnosis. There are some disorders in which genetic testing is helpful as well. And hopefully you came up with some of these, but these are some examples of rheumatic diseases and some that we're going to spend a little bit of time trying to identify signs and symptoms and the characteristics that are unique to each of these diagnoses. So what might lead you to suspect rheumatic disease? Again, these are some of the keys as we're trying to screen for these disorders and differentiate them from musculoskeletal conditions. So the onset is usually gradual and insidious because of the progressive nature and because of the immune response that's mounted. You could have an acute incidence if you have certain disorders. So a food trigger, such as gout, could induce kind of an acute flare-up of this disorder. And our joint or muscle pain that we might see is often widespread. So that's one key that's going to start making us suspicious of rheumatic disease, is that it's polyarticular. It affects multiple joints, or it can affect multiple muscles, multiple areas. It's often symmetric or bilateral instead of affecting one limb, one joint, one area, which is more commonly musculoskeletal. In rheumatic disease, remember, it's systemic, so it's going to be more widespread signs and symptoms, more widespread areas. And it's usually not caused by a specific incident, like we would see in a trauma or traumatic mechanism for musculoskeletal injury. And then again, we have these systemic signs and symptoms that are going to clue us in that something is going on within that immune system, not necessarily as a musculoskeletal issue. So those are really the keys, the ones at the bottom. So for these different rheumatic diseases, I want you all to take a little time on your own. You can pause this slideshow, and I'd really like you to fill out this table and try to describe what you might expect to see from each of these diseases and how you might start to suspect each one individually based on those keys or those clues to onset. So we've talked about the general flavor or general suspicions for rheumatic disease, but what specific signs and symptoms might you expect? What demographic characteristics might you expect to see in each of these diseases? So take a little bit on your own. Some of these you might be more familiar with than others, but really try to come up with a few for each before we move on. We will discuss each of these, but I want you to do that on your own. Okay? And how do we start to gain information to make these decisions and differentiate and screen for rheumatic disease? Well, we're going to go through our physical therapy examination. So this is our fundamental PT exam full of our subjective components, our objective components, and these are the nuts and bolts of your physical therapy assessment, differential diagnosis, and ability to prognosticate are going through these different components. You're very familiar with these. I just wanted to put this slide in here just to remind you that if you suspect rheumatic disease, these are your information gathering tools. You already have these tools at your disposal. We're going to discuss with which areas you might focus for certain rheumatic disease, but a lot of it is going to be subjective in nature due to the signs and symptoms or the symptoms that patients are going to report and history. You're going to gain quite a bit of information through that. So let's try out those decision-making skills. So, sorry, I skipped ahead a little bit. Our first case that I want to talk through, and this is a case example, it's going to be a 43-year-old male with right toe pain. So he went out last night for 25th high school reunion, woke up in the morning today with a swollen red toe. He's partial weight bearing, so he's limping a little bit. And that's all you know to start off. You're going to bring him back to your evaluation room. And what I want to know is, just based on this first bit of information, see if you can come up with 2 to 3 differential diagnoses that are musculoskeletal and 2 to 3 differential diagnoses that are non-musculoskeletal. Could be rheumatologic, could be other non-MSK diagnoses. And then I want you to think a little bit about why you chose those diagnoses. And we're going to go through, as we gain more information, a little bit of hypothesis testing, and maybe we'll get some evidence for these and some evidence against. But I think this is a useful exercise as we start to think about what components may lead us towards suspecting a rheumatologic disease versus ruling that out from our screening process. And then for your subjective exam, what other types of information would you like to have from this individual? What do you want to know? Just think about that before we move on. You can take some time. You can pause the slideshow if you want to. All right. So within your subjective, you start asking questions, you gain a little bit more information. This patient came to you, his wife had been a patient, so she highly recommended you, so he came right away. He didn't go see his PCPs, direct access. So you don't really have any imaging, you don't have any lab results, and starts to fill you in on what happened the prior night. So went out drinking for this reunion. He thinks he might have jammed the toe stepping off of a curb wrong, but he's really not sure. He's drinking. He doesn't have great memory for all the events that happened last night. It was really late. He did, as you start asking him about his previous medical history, prior medical history, he did have some pain in his ankle last year, but kind of went on its own. And he's never really had this toe pain before. His main complaint as he comes in is his toe is just completely swollen. It's aching, hurts to walk on it. He's really limpy. It's throbbing at rest, so it doesn't really go away. Best pain is 2 out of 10. It gets up to a 6 out of 10. And he has tried a little bit of ice and Tylenol that help a little bit, but don't completely relieve the pain. He has some prior medical history that he has indicated there. So based on the subjective information, you want to move on to your objective testing. What objective tests are you going to do to try to rule in, rule out your primary diagnoses? And then from your differential diagnoses list that you began with, has that changed? Do you have diagnoses that are maybe you're suspecting more, or maybe you're suspecting less based on this further subjective exam or subjective information? So think about that. Try to prioritize your objective tests as we go forward, and then we'll talk through some of the objective exam data that we got from this patient. Okay, so objectively, what are we going to want to do? Well, we're going to want to screen, we're going to want to go through some of our standard objective testing. And so findings here, and you can check out the notes in the slideshow for these objective tests. But what we really see is that his passive range of motion is painful in all directions. We don't really have a pattern of a muscle tendon injury. In other words, he has pain when he moves the toe. It's not really painful in a particular direction or painful to contraction and stretch in equal and opposite directions, which might indicate a muscle tendon injury. And varus and valgus testing at that IP joint produces pain, but the toe is just red and swollen and generally inflamed. You don't really notice any laxity, but mostly just pain limited at that digit. As we said prior, his gait is altered, so he has an antalgic gait. He's putting less weight through that toe. But overall, your exam findings are pretty inconclusive. You may go through your ankle and foot, your auto ankle rules, auto foot rules to clear for fracture, and he doesn't have any of the signs that you suspect for the fracture, the bony tenderness at certain areas. So you're kind of coming up a little bit empty with a conclusive musculoskeletal diagnosis. And at this point, your differential diagnoses have probably shifted to a top 1 or a top 2 at the end of this subjective information gathering and objective testing. And so what at this point is your PT decision? What are your subjective findings, objective findings, maybe top 3 differential diagnoses? So take a couple minutes. Again, you can pause the slideshow, think about those things. But as we think through this case, before we move on to our specific rheumatologic diagnoses, I want you to kind of think through and prioritize the information that we gained during our exam. As I mentioned, during our objective findings, we don't really have any tissue that we can narrow down that is a suspected pain driver beyond the potential for kind of a general sprain of that first great toe. He doesn't have any history of pain there, so that might indicate that a sprain is more likely. He does get a little bit of relief from ice and Tylenol, so that might indicate more of a musculoskeletal origin of pain. However, we do have to highly suspect an alternative cause for this pain given the other surrounding factors. So he does kind of fit the clinical picture of somebody who might have an acute onset of gout. So as we'll talk about further, and we get into this specific disorder, he's a male, he's greater than 40 years old. Those demographic factors put him in an increased risk. He kind of fits the stereotype in that sense. And then his mechanism, even though there's a possibility of a jam or a sprain, some trauma to that area, we're not necessarily sure that that actually happened because of the alcohol use and the poor memory. And he does have these predisposing things, or these factors that make us pretty highly suspect gout. So the demographic factors, he also has a potential food trigger. So we know alcohol can sometimes trigger a gout flare-up. The location of pain in his first great toe is a very common place for gout to manifest. He doesn't have any other pain complaints in other areas of the body that are consistent with a systemic disease. And he does have this acute onset. But as we'll see, gout can sometimes present that way. And he presents with pain at rest, which is one of those things that has to make us suspicious as we go through our musculoskeletal examination. Though it's not a complete rule out for musculoskeletal, we do know some conditions do manifest with pain at rest. Oftentimes individuals will have some sort of relief from a rest or a resting position, and where their pain will fluctuate and be relieved in some manner with some palliative treatment, or just with resting without putting weight on it. So at this point, we're thinking gout might be possible, but it could just be a toe sprain. So our productive physical therapy management at this point, we could make a case to refer right away to get a little bit further testing from a primary care physician likely. Or we could propose conservative physical therapy treatment, rest, continue with ice, see if he gets better. It's only been less than a day. See if he continues to get better with the natural history, monitor signs and symptoms, follow up with him. If he does not make improvement, then we could refer. So a couple alternatives to management, but we do want to have that diagnosis in our head of a non-musculoskeletal pathology, and namely gout or rheumatologic diagnosis.